The investigation to diagnose hyperparathyroidism. Welcome to our in-depth discussion on the investigations required to establish a diagnosis of hyperparathyroidism. Today, we will walk you through a logical and clinically sound pathway to accurately diagnose and classify hyperparathyroidism, ensuring that each step is clear and well explained for both medical professionals and those keen on understanding the subject. Let us begin with the foundational step, confirming the biochemical diagnosis. The classical biochemical triad for primary hyperparathyroidism consists of elevated serum calcium, an elevated or inappropriately normal level of parathyroid hormone, and a low or low normal serum phosphate. To start, we measure serum calcium, both total and corrected values. Hypercalcemia, or high calcium in the blood, is a hallmark of primary hyperparathyroidism. It is important to note that total calcium can be affected by the levels of albumin in the blood, so corrected calcium must be calculated when albumin is abnormal. Additionally, ionized calcium, which is the physiologically active form, is considered the most accurate test, particularly when albumin is low. The next key test is the parathyroid hormone level. The modern intact assay is the standard. In primary hyperparathyroidism, there is an elevated or high normal parathyroid hormone level in the presence of hypercalcemia, confirming the gland's autonomous activity. In contrast, non-parathyroid causes of hypercalcemia, such as malignancy, present with suppressed parathyroid hormone levels. In secondary hyperparathyroidism, the parathyroid hormone is elevated, but the serum calcium is low or normal, which is an appropriate physiological response to low calcium, as seen in conditions like kidney failure or vitamin D deficiency. In tertiary hyperparathyroidism, both the parathyroid hormone and the serum calcium are high, typically found in patients with long-standing secondary disease, such as those who have undergone a renal transplant. Another important investigation is serum phosphate, which is often low or low normal in primary hyperparathyroidism because the parathyroid hormone promotes phosphate excretion in the urine. Measuring vitamin D levels is crucial as well. Deficiency in vitamin D can mask the biochemical features of primary hyperparathyroidism, sometimes causing the serum calcium to remain within the normal range and making the parathyroid hormone appear only mildly elevated. Correcting vitamin D deficiency can reveal significant hypercalcemia in these patients. Moreover, assessing vitamin D is essential in ruling out secondary hyperparathyroidism, where a deficiency is the primary driver. Renal function tests, including serum creatinine and the estimated glomerular filtration rate, must also be performed to evaluate kidney health. Chronic hypercalcemia can impair renal function, and these tests are especially important for diagnosing secondary hyperparathyroidism due to chronic kidney disease. Once the biochemical diagnosis is suspected or confirmed, we move to supportive investigations to assess the impact of the disease on target organs. According to international guidelines, the first test here is the 24-hour urinary calcium excretion. This test helps distinguish primary hyperparathyroidism from familial hypocalciuric hypercalcemia, a benign condition that can mimic the disease. In primary hyperparathyroidism, urinary calcium is typically high or high normal, whereas in familial hypocalciuric hypercalcemia, it is very low. Calculating the calcium to creatinine clearance ratio helps support the diagnosis. To assess bone health, a dual-energy X-ray absorptiometry scan is mandatory in all patients with primary hyperparathyroidism. This scan screens for osteoporosis, often revealing a reduction in bone mineral density, especially in the distal one-third of the radius, followed by the hip and lumbar spine. In advanced cases, X-rays of the hands may show classic signs such as subperiosteal resorption, though this is not rare. For renal involvement, renal ultrasound is performed to detect kidney stones or nephrocalcinosis, both of which are important complications of chronic hypercalcemia. After establishing a firm biochemical diagnosis, we proceed to localization studies if surgery is being considered. It is important to note that these imaging studies are never used to diagnose hyperparathyroidism but rather to guide the surgical team. The first-line localization modalities include neck ultrasound, which is non-invasive, free of radiation, and can simultaneously assess the thyroid gland. However, it is operator-dependent and may not visualize glands in unusual locations, such as the mediastinum. The technetium negative 99 m sestamibi scan is also commonly used. This scan relies on the uptake of a radioactive tracer by mitochondria-rich parathyroid adenomas. Images are taken at intervals, and a persistent hotspot suggests the presence of an adenoma. This modality is particularly useful for detecting glands in ectopic locations and is often combined with ultrasound for optimal accuracy. When first-line tests are inconclusive or in cases of persistent or recurrent disease, advanced localization modalities may be required. These include four-dimensional computed tomography, which provides detailed anatomical information using changes in perfusion over time, and magnetic resonance imaging, which is especially useful for patients who cannot undergo procedures involving radiation or iodine contrast. In summary, the diagnostic pathway for hyperparathyroidism begins with the initial suspicion, often raised by incidental findings of elevated calcium, osteoporosis, kidney stones, or nonspecific symptoms. The diagnosis is confirmed biochemically by demonstrating hypercalcemia with an elevated or inappropriately normal parathyroid hormone. Differential diagnosis is aided by 24-hour urinary calcium to rule out familial conditions, and further assessments such as bone scans and renal ultrasound help evaluate organ involvement and guide management decisions. Preoperative localization studies are reserved for patients in whom surgery is planned, ensuring a targeted and effective approach. Thank you for joining us for this comprehensive exploration of hyperparathyroidism diagnosis. If you found this discussion valuable, please like, share, and subscribe for more episodes where we delve into the fascinating world of surgery and clinical medicine.